us about the political control of health care. We have an outstanding panel here today to talk about the topic. I'm going to make a brief introduction of each and then have them move more or less in the order that you see them here through without interruption from me, which probably wouldn't make it any better. Our guest who came the farthest speaks first, Brian Lee Crowley, who many of you will know from his writing on health care. Brian is the founding president of the Macdonald-Laurier Institute in Ottawa, a new think tank, very exciting. Ottawa, strangely, has not had many think tanks, and so despite the fact that it is a capital, Canada has some think tanks, but Ottawa has not. This is an exciting new venture. This is the second think tank he started. He's also founding president of the Atlantic Institute for Market Studies in Halifax. Brian Crowley is the author of 3 books, and the most recent is Fearful Symmetry, The Fall and Rise of Canada's Founding Values from Key Porter Books. Those of you who are based here in Washington, it's a hard book to get. It is a Canadian bestseller, which is very exciting. It's hard to get in Canada. We have for you copies available at the back of the room, and through the generosity of Brian's publisher, they're cheaper than list. You'd have to pay $35 for them if you bought them on Amazon, and we're selling them for only $30. And as a bonus, I think Brian can be persuaded to sign them after the event, which is you can go on eBay and then sell it for $35 or $40. It'd be fine. Brian's background in healthcare is more than just as a writer. He co-authored 2 projects in the Canadian healthcare system, both of which won the Sir Anthony Fisher Award. Many will recognize that award. In recognition of his healthcare work, he was named to the Alberta Premier's Advisory Council on Health, better known as the Mazankowski Committee. The chairman of that committee, Don Mazankowski, called Crowley the intellectual architect of the committee's report, which is no small praise. He's a frequent media commentator on Canadian healthcare in Canada and in the United States, has spoken at national and international conferences on this topic, and in March 2008, he was named a senior fellow at the Galen Institute, a free market health policy think tank here in the D.C. area, which is a perfect transition to my next speaker. Grace Marie Turner is the head of the Galen Institute. She's the president of the public policy research organization that she founded in 1995 to promote a more informed debate over free market ideas for healthcare reform, critical in the current environment, as you all know. Grace Marie has been instrumental in developing and promoting ideas for reform that transfer power over healthcare decisions to doctors and to patients. She speaks and writes extensively about incentives to promote a more competitive, patient-centered marketplace in the healthcare sector. Turner is also the founder and facilitator of the Health Policy Consensus Group, which some of you will be familiar with, which serves as a forum for analysts from market-oriented think tanks around the country to analyze and develop policy recommendations. She's the editor of Empowering Healthcare Consumers Through Tax Reform and produces a widely read electronic newsletter weekly called Health Policy Matters. If you don't subscribe, you should. It's one of the most insightful vehicles out there, particularly now. She's published in many major newspapers, from the Wall Street Journal to USA Today. She's appeared on ABC's 2020 program and on numerous radio and television programs, especially as this debate is heated up. In 2007, she received the Outstanding Achievement Award for promotion of consumer-driven healthcare from Consumer Health World. In the mid-1990s, Grace Marie served as executive director of the National Commission on Economic Growth and Tax Reform, and for 12 years she was president of Arnett and Company, a health policy analysis and communications firm. So Grace Marie is all of that and more. She's also the co-sponsor of this event. We're very pleased to have Galen co-sponsoring this discussion here today, so thank you very much. Finally, Tevi Troy is my colleague here as a visiting senior fellow at the Hudson Institute and a widely read writer on healthcare policy as well as domestic policy more broadly. In 2007, he was unanimously confirmed by the U.S. Senate as Deputy Secretary of the U.S. Department of Health and Human Services. As Deputy Secretary, Tevi was the Chief Operating Officer of the largest civilian department in the federal government with a budget of $716 billion, and I guess going up and up and up now, but even...
Not going down.
Absolutely. $716 billion, which was a lot of money even then. In that position, he oversaw all operations, including Medicare, Medicaid, public health, medical research, food and drug safety, welfare, child and family services, disease prevention, and mental health services. He served as the regulatory policy officer for HHS, overseeing the development and approval of all HHS regulations and significant guidance. In addition, he led a number of initiatives at HHS, including implementing the President's management agenda, combating bioterrorism, and public health emergency preparedness, something that we've benefited from quite a bit during the swine flu epidemic. He also sponsored a series of key conferences on improving HHS's role with respect to innovation in the pharmaceutical, biomedical, and medical device industries, and led U.S. government delegations to Asia, the Middle East, Europe, North America, and Africa to talk on these subjects. He has extensive White House experience, having served in multiple high-level positions over a 5-year period, culminating in his service as Deputy Assistant and Acting Assistant to the President for Domestic Policy, where he ran the Domestic Policy Council and was the White House's lead advisor on health care, labor, education, transportation, immigration, crime, veterans, and welfare.
What's left?
Is there anything left?
He did fairly well. And at the White House, he specialized in crisis management, creating intergovernmental consensus in all aspects of policy development, including strategy, outreach, and coalition building. He spearheaded the White House's American Competitiveness Initiative, which was featured in the 2007 State of the Union address. Tevi also served as Deputy Assistant Secretary for Policy at the Department of Labor, so he knows a lot about how all these issues hit the workforce, and was the department's lead regulatory strategist. At Labor, Tevi crafted the department's new ergonomics policy, as well as a plan for compliance assistance strategy for the department's regulatory and enforcement arms. Prior to his service in the administration, he's also held high-level positions on Capitol Hill. From 98 to 2000, Tevi served as the policy director for Senator John Ashcroft. From 96 to 98, he was senior domestic policy advisor and later domestic policy director for the House Policy Committee, then chaired by Representative Christopher Cox of California. So it's an august panel, and I'm the least qualified to be talking to you, so I will stop now, and if I can, ask you to welcome Brian Lee Crowley.
Thanks very much for that, Chris. A Canadian bestseller, eh? Some of you may have noticed that Fareed Zakaria not too long ago reminded us all that the New York Times held a contest not so long ago to find the world's most boring headline. Does anybody remember what the winner was? Worthwhile Canadian Initiative. The runner-up was Economist Dies. And as someone who is an expert in or started out my life as an academic expert in the thought of a dead economist, and being the writer of a Canadian bestseller, I feel like I have 3 strikes against me before I've even opened my mouth. But I'm going to try and tell you why you should take some interest in the Canadian healthcare system, even though it is explicitly off the table in this round of health reform. And I'm going to take my jacket off, if you don't mind, Chris, and I'm going to put it right there. The answer as to why you should take some interest.
You're not going to take anything else off, right?
No, I'm stopping there. I'm stopping there. Unless there's some interest in me going any further. The answer is that our system illustrates for you 2 things of vital interest to Americans in the context of the current healthcare debate. First, it shows what forces are unleashed when politicians, rather than patients and providers, start to take control of the healthcare system, especially in the form of the so-called public option, which is something I'm going to get to in a minute. Second, I think the Canadian healthcare system shows the dynamics that are unleashed by the creeping politicization of the healthcare system, ultimately resulting by slow degrees in something close to the Canadian system, even if most people did not want to travel to that destination. Maybe you could hand me my cup over there. A few years ago, thank you, our state broadcaster, the CBC, held a poll to identify the top 10 Canadians of all time. We managed to find 10. Our founding Prime Minister, Sir John A. Macdonald, barely made it onto the list. Pierre Trudeau, who fought the Quebec separatists to a standstill and introduced major constitutional reforms, including our Charter of Rights and Freedoms, only made it to number 4. Who came first? Does anybody know? Tommy Douglas. Who? Okay, Tommy Douglas. Tommy Douglas was the premier, the equivalent of a governor, of a small Canadian province called Saskatchewan. David, by the way, is a Canadian expert here, so he cheats. So Tommy Douglas was the premier of Saskatchewan. Saskatchewan, in Canadian terms, is what you would know as the quintessential flyover state. Now, what did Tommy Douglas do that has earned him the status of secular saint in Canadian politics? Well, he created what we now call Medicare, the healthcare system in Canada, a hugely popular system in Canada. And indeed, there is much that is laudable about the Canadian healthcare system. It is a system whose good intentions are writ large on the Canadian soul. And those intentions say that no one should be denied, needed medical care on the basis of ability to pay. To give life to these intentions, we created what might be thought of as the universal public option. Or, put the other way around, we got rid of all private options. We created a law that says that the state shall pay for all medically necessary services, the definition of which, by the way, is left, well, undefined. So how does that work? Well, Canadian Medicare operates essentially as an unregulated, tax-financed, pay-as-you-go monopoly. Our provincial governments are the monopoly providers. They not only pay for necessary care, but they also govern, administer, and evaluate the services that they themselves provide. They define what constitutes medically necessary services, and then they pay for virtually all such services provided in Canada. When I say virtually all such services, just to give you a sort of guide here, governments in Canada pay for 99% of all physician visits, compared to, say, France, where government pays for 60% of all physician visits. They negotiate payment schedules with powerful provider groups. They forbid the provision of private insurance for the services they provide. They often set the budgets for nominally private healthcare institutions. They appoint the majority of their board members and have the explicit or the implicit power to override management decisions. Now, anyone who doubts that provincial governments in Canada consider themselves and are considered by the electorate to be the governing mind behind the Canadian healthcare system, they failed to observe the election a few years ago in one of our provinces, Manitoba. And indeed, I will reveal to you now, the winner of that election is now our ambassador to Washington. In that campaign in Manitoba, the quality of toast in hospitals was a major election issue. And it was clear that the political parties, thought that they could and should be able to affect the quality of toast, and the electorate thought that this was a credible claim. Now, what's interesting is that in all of this went well beyond Tommy Douglas's intentions, the socialist premier of Saskatchewan, who is today revered as the founder of the system. How do I know this? Because at the end of his political career, Tommy was a member of parliament for a constituency on Vancouver Island. And in 1976-77, I was a parliamentary intern, which is the equivalent of a congressional fellow. And I became quite friendly with Tommy. So I well remember during a debate in the House of Commons about the further expansion of Medicare into some new area, the removal of yet some other aspect of the healthcare system not yet controlled by the state, Tommy turned to me and said, essentially, that this is not what he had intended to create. He had not wanted a system in which every hangnail could only be treated by the state, or in which no medical procedure could be performed unless government approved and the government had the money on hand to pay for it. What he wanted, what he set out to do, was to ensure that no one would lose their house because of illness, and that we would all share the risk of major sickness befalling us, which is a risk that we all face. Canadians, by and large, think that principle is just fine, and I agree with it. But even Tommy was taken aback by the dynamic that was created when politicians started to take control of the system. Tommy and Canadians thought that they were creating a system that would greatly expand the freedom and choices of Canadians, because no one is free if they are sick and cannot pay the bills to get well. We did not understand the trade-off we were being asked to make against other kinds of freedom. Now, lest you think that the toast example is a monumentally silly one of what's wrong with our system, and by the way, I agree. I only use it because of the mentality that it betrays. Let me use a different example whose consequences are obviously more significant. A friend of mine was the CEO of a major hospital in my home province, and like all hospitals in Canada, this was a nominally independent entity with its own board, and indeed relatively few hospitals belong to the government in Canada, but they are rather the property of not-for-profits. Still, government funding being the vast bulk of his budget, The next largest source of revenue for this particular hospital, and this would be common to almost all hospitals, after the money they got from government, the next largest source of revenue, anybody know? Parking fees. So you know whose tune this piper was playing. Anyway, this was a time of budget constraint, and the word had gone out to all the hospitals that they were absolutely to live within the budgets that had been established for them, no exceptions. And this CEO was deep in negotiations with one of his unions and was fighting ferociously to hold the line on the budget. And as a result, the union was threatening to walk out. In the middle of this, the phone rang in the CEO's office. He picked it up, and who do you think was on the other end? The Premier of the province. Remember, the equivalent of the governor. Now, what did the Premier have to say? You should settle. And my friend said, well, Premier, as I'm sure you know, I've been asked by the Department of Health, by your Department of Health, by your Minister of Health, to stay within the budget, and I can't settle with the union without breaking the budget. So I'm sure you understand that I have to be tough here. And the voice on the other end of the line said, maybe you don't understand. I'm the Premier, and I'm telling you to settle. Now, a benefit of the little story that I've just told you is that it introduces a very important new element into the discussion of what happens when the public option becomes the only option and healthcare becomes a government monopoly. As I argue in my new book, the discipline of the bottom line is absent in the public sector. Now, I don't mean to say that the ability of the public sector to pay is unlimited. Of course it isn't. On the other hand, private companies rapidly get into difficulty if they try to spend more than their customers and investors will give them voluntarily. Governments, by contrast, have the ability to take money compulsorily from taxpayers, just as they have the ability to shift the cost of current consumption of public services into the future by adding those costs to the public debt, something that America knows a lot about. Given that those who benefit from government spending are more effective and more politically active than those who pay, for reasons that anybody will know if they're familiar with the work of Jim Buchanan and the other founders of public choice theory, it's not hard to see where the convergence of interest arises between powerful and well-organized public sector unions and political authorities who generally want peace on the labor front and are willing to pay for it, either now or later. No government relishes the prospect of angry taxpayers finding their hospital doors closed or their doctors on strike. So what happens when you put together a public sector monopoly service like healthcare, but we could just as easily talk about the public schools or garbage collection, without a hard budget constraint, together with a powerful rent-seeking public sector union? You get hugely increased bargaining power for the public sector union compared to its private sector counterpart. If the unionized auto workers go on strike at GM or Ford or Chrysler, you can still buy a car from non-union Honda or Hyundai or Toyota. But if the doctors or the nurses go on strike in Canada, or the teachers or the air traffic controllers or the power workers, the service they represent is essentially withdrawn. And this draws the public into public sector labor disputes as a third party at the table in a way that they are hardly ever participants at the table in private sector negotiations. And politicians always have a nervous eye on voter discontent. I know this will come as a surprise to you, but I think I'm safe in this assertion. Seen in this light, the behavior of public sector unions and their analogs is entirely understandable. They resist to the death any attempt to introduce competition into the provision of public services through things like privatization or contracting out, and they naturally dress this up as the defense of the public good against the rapacious capitalists. But this is pretty transparent stuff. Try to imagine healthcare cost-saving debates in which every congressman and senator knows that one of the major employers in their district or state is the healthcare system, and that they, the politicians, are in charge and responsible for those systems in the eyes of the voters. Try to imagine that, unlike today, where employees of these organizations feel that their success is tied to providing good quality care to their community, that they quickly come to understand that their future success is tied instead to effective political lobbying in Washington. You will then begin to understand why it is that new infusions of cash into the Canadian system disappear without a trace. We get no improvements in productivity or health outcomes, while temporary shortening of queues is usually achieved by concentrating resources on politically sensitive procedures and letting the others slide. Now, my fear in the healthcare reforms I see debated so blithely here in Washington is that laudable objectives are being offered as the justification for a huge politicization of healthcare. That's just what happened in Canada. For reasons that I've explained, politicization, the drawing of politicians into ever more responsibility for healthcare decisions and outcomes, creates a dynamic within the system. It's a dynamic in which the politicians must demand ever more control over the system because they will be held responsible for what happens. Yet at the same time, the politicians are never willing to impose the ruinous taxes that would be necessary to fund a system in which people make their own decisions about their health care, but governments pick up the tab. Rationing is the inevitable outcome. And even though the system that is being proposed here in Washington may, at the outset, look like it is composed of many autonomous parts offering competing services, that was where we started in Canada as well. Most hospitals in Canada, for example, were and are private institutions. They long ago, however, lost the ability to act as private institutions. Physicians are paid almost solely by the government, and they increasingly are pressured by governments to think about the system rather than what is best for the patient sitting right in front of them. And the experience has been similar in many countries, where governments set up public insurance schemes in competition with private providers. Conditions are all too often created where private insurers cannot make money because, as demagogues so often claim, it's wrong to make money from sick people, or where they form a government-sponsored cartel and essentially cease to compete with each other in any serious way on price or quality. Where private providers where private providers face circumstances where they can only fail, government becomes de facto the monopoly supplier that I have described, even when it was the solution that no one wanted at the outset. And as Greg Mankiw argued the other day in the Wall Street Journal, the logic behind the argument for a public provider is a bit muddled. After all, isn't the argument to provide more choices to consumers by increasing the range of options? The claim is that the public provider will not be subsidized and will be a genuine bona fide level playing field competitor to private providers. But if you think about that for a minute, if a public plan could, as all other providers have to do, pay its own way out of income generated by its activities and the value of services that it makes available to consumers, what is it creating that doesn't already exist today? If a private provider could provide the proposed services and make a profit or cover their costs, wouldn't they do so now? It can't be the issue of profit because lots of healthcare providers today are nonprofits in America, as you know. In practice, however, if a public option is available, it will almost certainly enjoy taxpayer subsidy of one kind or another, and these subsidies may be rather non-obvious to the outsider. For example, will it have to provide its own buildings, or will the state provide them? Will it have to earn a return on capital, which is not the same as profit? Earning the appropriate return on capital is a signal that people value this service more than the alternative things that could be generated using that money for other purposes. Will the public provider have to pay taxes? What will happen if the public provider loses money? Who will pay the bill? And will providers of capital lend on the assumption that the public provider enjoys an unofficial government guarantee giving them access to low borrowing costs? And according to Mankiw, I quote from his article, such explicit or implicit subsidies would prevent a public plan from providing honest competition for private suppliers of health insurance. Instead, the public plan would likely undercut private firms and get an undue share of the market. President Obama might not be disappointed if that turned out to be the case. During the presidential campaign, he said, quote, if I were designing a system from scratch, I would probably go ahead with a single-payer system. Let me open a small parenthesis here and say single-payer is a weasel term for government monopoly. Close that parenthesis. Of course, we're not starting from scratch. Because Americans are happy with their current health care, moving immediately to a single-payer system is too radical a change to be politically tenable. But for those who see single-payer as the ideal, a public option that uses taxpayer funds to tilt the playing field may be an attractive second best. If the subsidies are big enough, over time, more and more consumers will be induced to switch. Ultimately, private competitors are forced out of business or drawn into a government-controlled cartel. And then you have, essentially, the Canadian system of monopoly control of health care. The system that President Obama says he would choose if you were to design the healthcare system from the ground up. Here is why we have learned in Canada that single-payer or government monopoly squeezes out the power of patients and their families. In a competitive environment, consumers are free to vote with their feet. Over the years, they have come to prefer calculators to slide rulers, natural gas and oil to coal, Twitter and email to snail mail, even though in most cases the old dominant industry that was being abandoned was powerful, rich, and well-connected. But in a monopoly, even a regulated monopoly, the relative power of consumers and suppliers is completely reversed. Before the advent of competition in the telephone industry, we've all, those of you who are old enough to remember, I certainly am, before the advent of competition in the telephone industry, dissatisfied customers faced the massive indifference of a bureaucracy that literally could take their business for granted despite some theoretically powerful regulatory agencies. Administrators of the Canadian healthcare system likewise suffer no direct consequences as a result of poor customer service. They aren't even answerable to a regulatory agency. Accountability is some vague political concept which cannot be enforced in any meaningful way. And the politicians neutralize the dangers of this system by all swearing allegiance to the system and arguing only about who will do more to prop it up, while in fact squeezing it through ill-designed centralized controls. And like all monopolists, Canada's healthcare authorities abuse their position of power. And they do so in accordance with the famous economic insight that the best monopoly rent is the quiet life. Because, of course, our public sector monopolists are in a conflict of interest, in which they are both the providers of healthcare services as well as the people charged with evaluating the adequacy and the quality of those services. By being both provider and evaluator, these monopolists grant themselves the quiet life by the simple expedient of having virtually no hard measures of success. What we do know is that the doctor shortage is now so severe that Statistics Canada reports that roughly 4 million Canadians do not have a family doctor, and family doctors are now engaging in lotteries to cull their patient lists. The coming wave of boomer-driven retirements of physicians will only exacerbate what is already a critical situation. Canada's public health care system is undersupplied compared to many industrialized countries, with the latest diagnostic and other technologies such as MRIs, CT scanners, and so on, because these technologies are expensive and, most importantly, their use leads to more consumption of healthcare services, because people with quicker and higher quality pictures of their health conditions then expect those diagnoses to be acted upon. Just as doctors have come to be seen within the Canadian healthcare system as cost centers. There's a famous health economist in Canada who woke up one day and said, my God, everywhere where there's a physician, there are a lot of billings to Medicare. So the solution to our cost problems is let's have fewer doctors. This alleged healthcare economist apparently had never been introduced to the concept of supply and demand. The logical prescription, as one healthcare report underlined, one federal government report underlined, new medical technologies are only a cost driver in the system if you use them. So the logical prescription, keep your healthcare system primitive and your costs will be kept low. And lest you think I'm making this up, the 2009 Euro-Canada Health Consumer Index report, prepared by a think tank in Canada and one in Brussels, rates Canada in the lower third of the index. This is comparing Canada with all European healthcare systems. So Canada is rated in the lower third of the index, competing with countries like Slovakia, Lithuania, and Poland, all ex-planned economies in formerly Soviet-occupied areas. And by the way, the very different U.S. system prevents it from being included in this index. So we can't compare the United States in the way that Canada is being compared to many of its European opposite numbers. According to one of the authors, Johan Hjertqvist, of this report, and I quote, Canada keeps up in only one of the 5 index segments, that is to say, outcomes. And that seems to reflect the Canadian approach. If the treatment outcomes are decent, you can stand long waiting, limited choice, and lack of information. The healthcare index, by contrast, takes a more holistic stand where many characteristics together form the quality of care. And when all these factors are taken together, Canada does quite poorly. If we focus on medical outcomes alone, the picture is more favorable. In other words, if you can get the Canadian healthcare system to take you and your health problems seriously, if you can navigate the many obstacles to timely and effective care, the care you actually get stacks up very well against other healthcare systems. But those ifs are not minor quibbles. Those ifs are major problems with the system. With respect to direct comparisons between Canada and the United States, the reliable data are, I'm sorry to say, rather few and far between. One exception worthy of note is a 2004 study carried out jointly by our two national statistical agencies, Stats Canada and the National Centre for Health Statistics, and they say, I quote, overall, more Americans reported that they had experienced an unmet health care need in the previous year compared to Canadians, a difference of 2 percentage points. 13% of Americans reported an unmet health need, 11% of Canadians reported an unmet health need. There was no difference in the proportion who reported unmet health care needs between Canadians and insured Americans. The top reason, however, for unmet health care needs differed between the two countries. Waiting times was most often reported in Canada, and cost was most often reported in the United States. Americans, on the other hand, are more likely to be very satisfied with their health care services, both all services and doctor services, while Canadians were more likely to be only somewhat satisfied for all services, even when compared with insured Americans. Finally, just so that I don't leave you with the impression that I think all is doom and gloom with the Canadian healthcare system, there's a key part of the Canadian system that's totally exportable, significantly lowers the cost of health care, and doesn't harm the investment climate for pharmaceutical and other medical innovations. And that is this: in Canada, you can't make money suing drug companies, doctors, or hospitals. So what I call the tort tax, a tax paid by every user of the American healthcare system, isn't priced into Canadian drugs or hospitals or physician costs. Today, the entire U.S. healthcare system is, as you probably know, a feeding ground for trial lawyers. In the city of Chicago, just to pick one example, obstetricians pay $230,000 a year in annual malpractice premiums. That's more than most Americans earn in several years of very hard work. And it's why many doctors are refusing to deliver babies. Things couldn't be more different in Canada. Jury trials in civil cases, while not unknown, are extremely rare. Judges have far more control over questions put to the jury, and there's much greater latitude in appealing jury decisions. The Supreme Court of Canada has also effectively capped awards. Punitive damages, which are commonly awarded in the United States, are very difficult to get in Canada. Our courts punish genuine harm and wrongdoing, which is what you want them to do. They are not used for arbitrary redistribution from those with money to those with a sad tale to tell. By contrast, the U.S. system imposes a huge tort tax on health care costs that Canadians don't pay, and that tort tax isn't just built into the cost of drugs, for example. It also drives many of the costs of your health care system through so-called defensive medicine. By the way, every Canadian I know who practices medicine in the United States, without exception, says the thing they hate the most about the American system is defensive medicine. Or the ordering of many tests and procedures, not because they're thought to provide real health benefits to the patient, but because they provide real legal protections to the provider. Canadians who practice medicine in the United States put it at the top of their hate list. I think you would find that the best possible reform of your health system, and one that would genuinely reduce costs, would be to introduce elements of the Canadian legal system, not the healthcare system. To sum up, as healthcare moves more and more into the public sector, politicians and bureaucrats feel the need to control outcomes because they will be blamed for unpopular outcomes, no matter how necessary, and they will be lauded for popular ones, no matter how absurd. Remember the quality of toast. The politicians also cannot face imposing the taxes that would be necessary to fund every medical service that might be requested by someone, and the only possible outcome is therefore centralization and rationing. What is the moral of the story? Be very careful what you wish for, because the unintended consequences of changes to complex systems like healthcare, the unintended consequences, do far more damage than can ever be compensated for by the intended benefits. Healthcare systems such as yours have grown up through a very slow and deliberate process of trial and error. Simplistic reforms based on inadequate knowledge of these complex systems often ends up upsetting delicate balances amongst powerful forces in the system. And once the old system is destroyed, decision makers are often drawn, as they were in Canada, ever deeper into the wholesale replacement of the system with something inferior, even when it was never part of their intentions. Policymakers can often, with the best of intentions, put in place policies that achieve the exact opposite of what they wish to achieve for people. Wishing to do good, they end up doing incalculable harm. It is not just the road to health care reform that is paved with good intentions. Thank you.
Thank you very much, Brian. Thank you for joining us here, and thank you for your always wise insults. Interesting. Insights.
I've saved the best for you.
Insights. And I guess, insults to the American political system for thinking that somehow we could get a single-payer system right. And thank you for sharing that. Thank you very much, Tevi, for joining us. And thank you, Chris, for co-sponsoring this event with us. We really appreciated the space and the reception. Tevi and I will both just offer some brief comments, and then we will invite your questions, and we will invite you then for a casual conversation and reception afterwards, and hopefully all of you will see the wisdom of learning from Brian and purchasing his best-selling book. A quote comes to mind listening to Brian talk about the unintended consequences of health reform from someone who was talking about the system in the United Kingdom, where there was waiting lines and waiting times in operating rooms were no longer being judged by hours but by days. And this became a huge political problem, much like toast in the Canadian system. And so an edict came down from Parliament that waiting times will be reduced in emergency rooms. Money was poured into the system so that people would not have to wait so long. For many people, that's their only access to care. But they didn't really increase capacity. They just political dictate that waiting times must be reduced. So the hospitals became very creative. They decided that, the definition of a hospital bed is a bed that doesn't have wheels. It's fixed. So they took the wheels off the gurneys. They still were parking patients in hallways in the emergency rooms, but technically they'd been admitted because they'd taken the wheels off of the gurneys and called them hospital beds. So according to the statistics, they had improved the wait times in hospital emergency rooms. Other hospitals decided, we're just simply not going to let people into the hospital, and we are going to keep them in ambulances. And so ambulances were driving around the streets of London for hours before hospitals would allow them to be admitted. So the queue just was basically outsourced to the ambulance system. So those are the kinds of unintended consequences that result when you've got bureaucratic control and political imperatives to meet, and even creative bureaucratic means to go around them. And oftentimes it's much more serious than taking the wheels off of gurneys. It is really access to life-saving medical care. And one of the systems that the UK uses is the National Institute for Clinical Excellence. What's it called? Your equivalent of NICE in Canada, the rating and the regulatory agency.
Well, Health Canada would be the closest. We don't really have a NICE.
But it's a system in which the government's deciding what treatments and procedures are going to be allowed. And of course, the stimulus bill that was passed in February contained $1.1 billion to create our own National Comparative Effectiveness Review Council. More money certainly is coming through the various bills that are making their way through Congress, so that the federal government will begin to make determinations about what medical treatments are and are not allowed. And we think, oh, well, it couldn't possibly become so draconian that government officials would deny people cancer treatments. It would simply be making sure that our healthcare system is more efficient. But today's Wall Street Journal carries an editorial talking about Washington State already in practice. They have something called health technology assessment. It's a commission, but it's called health technology assessment. That is basically to determine whether or not the state of Washington is going to pay for procedures for Medicaid patients, public employees, and prisoners. So far, the Commission has banned knee arthroscopy and for osteoarthritis, discography for chronic back pain, and implantable infusion pumps for pain not related to cancer. This year, it's targeting such frivolous luxuries as knee replacements, spinal cord stimulation, a specialized autism therapy, and MRIs of the abdomen, pelvis, and breast for cancer. It's also to rule on routine ultrasounds for pregnancy, which have high efficacy, but also a high cost. They are going into drug-eluting stents. So we can see that once you set these policies in place, even a country that we believe is based upon freedom and independence and market-based responses to customers' needs, once you have so much political control over the payment policies, you wind up devolving control over decisions about basic medical care. And it talks about just medical stents. It's currently the Commission is pushing through the most restrictive payment policy for drug-eluting cardiac stents. Those are the ones that actually continue to produce a drug so that the blockages will not come back, instead of simply bare metal stents. So if a patient is wheeled into an operating room with chest pains in an emergency, doctors will first have to determine if he's covered by a state plan, then the diameter of his blood vessels and his diabetic condition to decide if it's an appropriate stent. If they don't, the state of Washington will not reimburse them for inappropriate care. So that's basically where it goes, with political decisions over really truly life and death, even in emergency room situations, rather than having doctors and patients in charge of medical decisions. And there's a wonderful quote from Paul Starr, actually, who was an advisor to the Clinton administration in 93, 94, in his book called The Social Transformation of American Medicine, where he said political leaders since Bismarck have found that they could use insurance against the cost of sickness as a means of turning benevolence into political power. And I think that really gets back to Brian's quote that laudable objectives can be used as justification for a huge politicization of health care. And we see in an Associated Press poll out today that the American people absolutely agree with the goals of healthcare. We want to get to universal coverage. We want costs to go down. We know that there are much greater efficiencies that can be gained through our healthcare system. But when you get to the details of how they're going to do this, the American people recoil. And you start to see the numbers absolutely flip, where politicians are making decisions about health care and whether or not we all must have health care. They want universal coverage, but when you start to say, but we're going to enforce that with fines, penalties, possibly even jail terms, no thank you. That's not the way we want to go. So clearly we've got to start in a different direction, and we've got to start with a new approach to solving these problems that really does not devolve so much political power to Washington, but moves it to doctors and patients with the right kind of incentives so that we cannot have to follow from failed systems that move more and more power to bureaucracies, but really lead the world to new systems that restore power and control to doctors and patients, rely on innovation and competition, patient choice, and the power of innovation in medicine to solve these problems, and not believe somehow or another that this is something that could be fixed through bureaucracy. Thank you very much. Tevi.
In the interest of brevity and informality, I'll give my remarks from here. The introductions you gave, Chris, were very intimidating because I found that I am the only person on the panel who's not a serial think tank beginner or starter. So I hope you will still find my words worth listening to. I thought Brian laid out a very frightening vision of what could be in store for us in America, of a system that I think Americans don't want and would not enjoy, and would ultimately reject, even if it were imposed on us for a short-term period. What I often find in this debate is when you have Americans, certainly Americans on the conservative side, debating Canadians or British or people from the British system. There's often a sense that we're kind of insulting their systems, because we say, well, there's long lines in Britain, there's poor care in Canada, et cetera, and so it seems that Americans are often insulting to our some of our closest friends and allies, and I would like to kind of take it from a different perspective, which is no interest in insulting the British or the Canadian system. I think Americans are just different. We want our own type of system. I think we kind of established the paradigm for a system that is, while imperfect and inefficient and has some flaws, many flaws, and I think in the 1960s we kind of established a kind of working compromise. And this working compromise came after the establishment of Medicare and Medicaid, where we said, for the most part, we're going to have a private healthcare system where people have to obtain health insurance on their own, unless you are in certain categories. And the categories are the elderly, the disabled, and poor. The poor people are the ones get Medicaid if they're a certain level of poverty. Obviously, the elderly get Medicare, and that's kind of the system we established. Now, I don't think we quite realized back then what we would end up with. There are stories that reports trickled out, budget estimates trickled out of the LBJ White House, that the cost of this new Medicare Medicaid system. It's actually interesting. They were supposed to be, they were two separate and competing proposals. One was for Medicare and one was for Medicaid, and they actually got merged together by the chairman of the Ways and Means Committee. It was sort of a clever trick to bring everything together, and suddenly they had this one large program, and the estimates came out that this might cost $1 billion, and Lyndon Johnson, supposedly, as only Lyndon Johnson could do, admonished his aides in the strongest possible terms for letting that terrible long-term estimate come out. Now, obviously, the system now costs well more than $1 billion, and right now the reforms they're talking about are in the area of about $1 trillion just for the reforms of the system. But the Center for Medicare and Medicaid Services, CMS, which handles both Medicare and Medicaid, is about a $500 billion agency right now, just that one agency. So it's not exactly the way we turned out, but I think for the most part Americans kind of had a feeling that this is what would work for us. And again, we're not the Canadians, we're not the British, we want to do our own thing. Now, obviously, doing it this way has had consequences, and there are certainly some inefficiencies. I think we've also seen a deviation from this notion that people pay out of pocket. And the Wall Street Journal had this interesting chart that showed since the creation of Medicare and Medicaid, the amount of overall spending on healthcare has gone up. In fact, it's about quadrupled. But however, out-of-pocket paying has gone down steadily. Now, that's not all of it just because of Medicare and Medicaid. It's also the insurance model that we use now is more people paying an insurance company, and they pay very little out of pocket. And it used to be that there was more out-of-pocket paying, and that gets to what I know Grace Marie likes to talk about, which is more of a consumer-driven model. When people pay a little more out of pocket, they have a better sense of what the costs are, and that can have an impact on prices in terms of reducing the prices, and because consumers start making smart decisions. And we've seen this in so many different areas in terms of large screen TVs and cellular telephones, telephone service, and even in the healthcare areas that are not covered by insurance, like LASIK. You've seen the technology improve and the costs go down when people are more invested in how much the costs are directly to them. So I certainly think that there have been some inefficiencies in the system that do need to be fixed. And so I am an advocate of healthcare reform, but I think what they're talking about these days does not constitute reform. It would certainly cover more people at the end of the day, but it would do so in a very expensive way. I already said it would cost about $1 trillion. Now, some people say it would be deficit neutral, as if that means that it wouldn't cost anything. I mean, the costs still remain, even if you find ways through higher taxes and Medicare cuts to pay for it. But the fact remains that it would be a $1 trillion program, and it would not really do what President Obama laudably laid out, which was to bend the cost curve down. I would love to see some really smart reforms that start bending that cost curve down. Right now, the healthcare reforms are pretty much are focused on the benefits, getting more people covered, and doing it in a somewhat, in a very expensive and somewhat clunky way. So I'm concerned about how that approach will work. Actually, not work. I think what would happen is if the current bills do pass, you would see an increase in the number of people being covered. So the problem of the uninsured would get smaller, although not disappear even under the more expensive House bill. But you would not really see a solving of the problem of costs. In fact, the problem of costs would worsen. And I think we would have to take another bite at this apple in a relatively short amount of time and start opening up the question of healthcare again, which I know many politicians are probably loath to do after the ugliness of this past season. So I think that is a concern. I also want to talk a little bit about, I think Brian talked about with one of the disadvantages of the Canadian system is no improvements in technique. And you gave the quote that new medical technologies are only a cost driver if you use them. And I, myself, in my experience as Deputy Secretary at HHS, saw some of this attitude in CMS, the Center for Medicare and Medicaid Services, once we had a conversation about NCDs, National Coverage Decisions. These are the determinations by which CMS decides if they're going to pay for a new technology or a new drug or a new device. And these are extremely important, not because CMS is such, not just because CMS is such an important player in the healthcare market and pays for so much of healthcare, but also because the insurance companies tend to follow suit. If CMS makes a decision, a coverage decision, it is often the case that the insurance companies will make a similar decision and justify it by saying this is what CMS did. And what I often found was that there was precious little science behind what CMS was determining what they would cover and they would not cover. And we had a conversation about the national coverage decision process, and Secretary Leavitt was very interested in this process. And one of the leaders at CMS was who'd been a career official for more than 2 decades at HHS, said that never in the history of CMS has there ever been an NCD, a national coverage decision, that saved the government money. And I think that's very much the kind of attitude you're talking about. It's technologies don't cost money if they're not used. And but if they're not used, they also don't save lives. So I am very concerned about some of the approaches that we're taking that would take away America's role as the leader in healthcare innovation and in the development of new healthcare technologies. And I think the more that you have this slouching towards rationing, this movement towards more government decision making about what products get covered and what doesn't, what products get approved and what don't, that's when you start to get in this area of tougher and tougher decisions about what new products get researched and developed. And I think it's the research and development that the U.S. has really been a leader of throughout the world for the last 4 decades in a time when we've seen huge improvements in medical technologies in terms of longer lifespans and reduced death rates and all sorts of new and innovative techniques that really do save lives, and they have an impact throughout the world. So while we may disagree with our friends in England or in Canada about the best structure of the system, I think everybody agrees that the U.S. has really been the driver of new innovation technologies. And I worry that if we move too far in the direction that Grace Marie was talking about and that Brian kind of laid a frightening vision of in Canada, I think if we move too far in that direction, not only will we move away from this bargain that I think we came up with in 1965, but we'll also move away from the U.S. being a leader in healthcare technology. Thanks.
Good.
Well, thanks to all of you on the panel. We have some time for questions between now and 5:30, and we'll have a reception shortly after. I thank Grace Marie because she mentioned that, and I had failed to mention that at the outset. So those people who left before Grace Marie started talking, that's my fault. I'll have to buy them a beer or something. Yes, that's true. Before I go to the audience, do any of you want to comment on each other's remarks? Is there any hot pursuit comment that you'd have? If not, let's go to the crowd.
I had my say.
We've got lots of questions.
There's a gentleman here with a microphone, and because we're recording the event, it would be helpful if you get it before you speak and just tell us who you are and where you're from and get started. Do you want to start with the gentleman there? Yeah, that's fine.
Hi, my name is Jamie Weinstein. I'm a writer for the North Star National. My question is, just get your comments on, Harvard economist Martin Feldstein published an op-ed about a month ago in the Washington Post about maybe an alternative policy, the outlines of which were basically you would be responsible for up to about 15 to 20% of your health care coverage individuals would be, and after that there'd be some type of catastrophic plan where there'd be a subsidy or something along those lines. What are your thoughts on that?
Do you want the same order? Or? Yeah, do you want to start, and then we'll move on?
Well, I'm a big believer in the idea that people should participate in in decisions about their health care, including about what their health care will cost. And I think there's lots of evidence, including from the RAND study that was done some years ago about what happens when people are faced with some co-payment or whatever around their medical decisions, that people's health status did not suffer, but their spending went down. And so I think there's good evidence that creating a system in which people actually have to pay something for access to basic medical costs is a very constructive reform of the system. Of course, nobody frivolously has open heart surgery, right? This is the thing that we have to remember, that there are many kinds of healthcare costs that people do have control of, and there are other kinds that they don't. And I think the whole idea behind catastrophic insurance and having that compulsory is that we want to insure people against the things that they couldn't possibly pay for out of pocket, but require them to be able to cover lower cost things over which they have more control. And to the extent that Marty's piece described a system like that, I think it's a very positive contribution.
And if we were to really think about making sure everybody has health insurance, that if they go to a hospital, they get a serious illness, they're covered. That is something we could do. The reason we're having the problems we are in getting to universal coverage in this country is because we think that everybody has to be promised an incredible gold-plated Cadillac plan where they have virtually no out-of-pocket responsibilities and therefore very little incentive to use the system wisely. So a system in which everyone has catastrophic coverage would both be much more affordable. It would give people insurance protection, and then the system that Professor Feldstein was talking about helping people with money for routine care basically is built upon the health savings account model, which has been shown to reduce health care costs and to provide an incentive for employees and employers in particular to be partners in managing health care costs. It's one of the few places in the private health sector that you actually see very modest cost increases and sometimes even cost reductions in health care because you start to get the incentives right.
Yeah, that's a good question. I agree for the most part with my colleagues here at the panel, and I think it is important, even though I don't know all the details of the Feldstein plan, so I don't want to endorse it specifically, but it is important to have catastrophic coverage so you don't have this issue that Brian was talking about earlier of people going broke or losing their house from healthcare catastrophes, and also that everybody has some level of coverage, but also people have skin in the game, that people have some level of participation in their healthcare, and that can help drive costs down. And what I would take from the question and from what Professor Feldstein said is that we do need more discussion of alternatives. I think that the discussion thus far about healthcare reform in this country has been very limited and looking at only one type of model, which is this heavy mandate and subsidy model, and I'm not sure that works. I would urge people to look at the GOP alternative bill, the House Republican bill, which was certainly imperfect. It did not nearly increase coverage by the amount of people it needed. But the CBO found that it did decrease premiums, insurance premiums, over a 10-year period, and it was not only deficit neutral, but actually reduced spending over a 10-year period. So if we could find some kind of alternative that could actually increase the number of people covered to a sufficient amount and also do those other things, I think that would be very worthwhile doing.
Tevi, before we go on, I know several of you will know we attempted catastrophic coverage once before. What went wrong with that?
This is the Roskindowski Cadillac story, right? So there was a famous story of I'll let you talk about it a little more, but there's a famous story that the catastrophic care, because it made I think it was limited to Medicare, right? And I think it made a lot of seniors were very unhappy about what they saw as an increase in their out-of-pocket spending. They chased the chairman of the Ways Committee, Dan Rostenkowski, down an alley in Chicago, and one of them actually laid across the hood of his Cadillac and tried to stop him from driving away.
I've ever found a picture of that. Sure.
I think you were involved a little bit in that. Do you want to talk further about it?
Actually, I think we've got plenty of questions. Let's see if we can move
Fair
and maybe
enough.
be more efficient
We're
in our
working
answers.
our way through, but we'll catch you all. Yes,
Yes.
sir.
My name is Jamie Huckabee. I'm a graduate student at Johns Hopkins SAIS. My question is that in Canada, we saw innovation begin at the provincial level in Saskatchewan, and it slowly expanded for a variety of reasons to the country as a whole, within each province. We've also seen some innovation at the state level in the United States. Could the panel talk about the effects that we've seen? You mentioned that Washington State, I know Massachusetts has had some reforms. What have been the dynamics a few years in from that, and what could we learn for the debate at the national level?
Of course, I will refrain from commenting on the American thing because obviously my colleagues here are far more knowledgeable than I. What I can talk about is Canada. And it's true that a lot of the reform that we brought in Canada originated in the provinces, and the provinces have been kind of laboratories of experimentation. But I believe it's also the case that once the federal government got into major transfers to the provinces with strings attached to finance healthcare spending, that a great deal of the experimentation came to a halt. And that if you compare healthcare spending and healthcare reform in Canada with welfare spending and welfare reform, there's a very important object lesson for both Canadians and Americans. What happened in welfare spending in Canada was that the government of Canada used to transfer a lot of money to the provinces to help them cover welfare costs. That got to be too expensive. They had an open-ended program in which they said, if you provinces spend $1 on welfare, we'll give you 50 cents. And so the provinces were the ones who had the budget decisions to make, and Ottawa just wrote a check for half of it. As long as they could pass along half the cost to Ottawa, the provinces didn't care about the effectiveness of the system. When Ottawa said, we're ending the 50% shared cost program, we're going to a fixed block grant, you're not going to get any more, that's just what it is, all of a sudden the provinces started to experiment with welfare reform, and we got various different approaches to welfare reform that focused on different things in different provinces and were hugely successful. And it seems to me that that model, we need to move to that model in healthcare in Canada. I'm quite convinced that the provinces would do a tremendous amount of experimentation if they were no longer in a position where they could say, well, the reason that we're not able to give you, our local voters, the healthcare you want is because Ottawa's not giving us enough money. And there's a tremendous amount of interjurisdictional finger-pointing, which is a substitute for actual intelligent thought about system reform.
Brian, I think that's a really good analogy also of the United States, where welfare reform really did evolve in the states, Wisconsin model in particular, with Tommy Thompson taking the lead and showing that we could do welfare to work, and that became the incentive for a national model. Healthcare is not going that direction, partly because healthcare is so local. It's much more determined by benefits rather than simply writing a check to somebody. And there are so many differences in the states. I mean, Massachusetts has a very different approach to solving the problems in its health sector than, for example, Utah does. And they are worlds apart. And what Washington is coming up with has nothing to do with anything that Utah is doing. It's actually much more based upon the Massachusetts model, which is, by the way, I think beginning to show the cracks of failure. They are absolutely not able to get a control of costs. Their costs are still the highest in the nation. They have tremendous problems with access to physicians. People were told that there would be a reduction in use of hospital emergency rooms. Hospital emergency room use is 14% higher in Massachusetts. So we're building on a model that we know isn't working when we've got other models in the states that are working, the Massachusetts Health Exchange, for example, or the Utah Health Exchange, for example, that really is showing progress. So I think probably both because of the complexities of healthcare and because of the incredible differentiation among the states in this country, and this vast country of 300 million people, that it's very hard for one federal model to be imprinted on this country that's going to work for everyone.
Yeah, I too am a fan of experimentation at the state level and the states as laboratories of democracy, et cetera. But I am concerned with the current contentiousness of our system. Sometimes you can't get people to agree on what actually is going on. You know, there's the famous saying that everybody's entitled to their own opinions, but not everybody's entitled to their own facts. Well, this time we appear to have, each party has their own facts, and they only look at the facts that bolster their case, which means that the Democrats look at the Massachusetts and say, hey, how great this is, and the Republicans look at Massachusetts and say how terrible it is. And right now, I don't see us using the laboratory model sufficiently well where we could actually agree on what's working and what's not.
We've got a couple in front.
Yes, my name is Kurt Windsor. I'm a trustee of Hudson and of the Donner Foundation. I'd like to address a question to the two Americans on the panel, and that is, much talk has been offered about the inefficiency of our insurance monopolies at the state level. And this is an issue of fact, and I haven't seen it backed up with numbers. What would be the saving overall if we were to abolish the monopolies and allow, in effect, health plans to bid nationwide instead of the present really ridiculous and self-serving system that we have?
No, that's a very good point. In some states, one health plan may control as much as 70 to 80% of the market, and a lot of that is because of state regulation that becomes very protectionist for those providers. They certainly can't drive them out because there's nobody else offering that insurance. So state monopolies have become a very big cost driver in the system. And in fact, the bill that Tevi mentioned, the Republican alternative that was introduced as an amendment to the House Health Reform Bill late last week ago Saturday night, did include a provision that would have allowed cross-state purchasing of health insurance. That was one of the contributing factors that the Congressional Budget Office said led to lower costs, increased competition, and began to move the cost curve in the right direction. So allowing cross-state purchasing of health insurance in the national market would increase competition and give people more choices and more affordable coverage.
Does anyone have numbers, though? Because if we say this in the present environment, it rings as hollow as the other side's claims, unless we can come up with some estimates on what would be
Bob, do
saved.
you have a number?
Tevi, have you seen the, we need the microphone over here. Tevi, Bob, did you look at those numbers, whether or not CBO actually analyzed that particular part independently?
I can't quote you the numbers, but
Parente.
people up at the University of Minnesota
Yes, Steve Parente.
have actually done some estimates of that, and it's substantial.
Yeah, that's right. Steve Parente with the University of Minnesota has done some work on that, and if you give me your card afterwards, we'll make sure that you get that. Put it on our website. And Roger Feldman and Steve Parente, right.
Could you tell us for the record who you are after all?
I'm sorry.
Bob Helms with AEI.
Okay. Known to the panel, but wanted to share that with us. All right. Next question.
My name is Fred Hunt. I'm president of the Society of Professional Benefit Administrators, or third-party administrators of about over half of U.S. workers. There's also a Canadian Society of TPAs. I also personally have a lot of connection between Canada and the U.S. and a lot of interest. It's interesting. I started in this issue back in 1974 when both ERISA was being passed and was being told that was the end of the world. Nobody would ever have an employee benefit plan again. And also, the Republican Nixon administration came up with a plan which, if you look at it, is amazingly close to today's program. And the Democrats went, we wouldn't have anything to do with that. So it's a little kind of fun to play with and say, gee, don't you, if they had offered the Nixon plan, and I'm not in favor of it, but if they had offered it, imagine the political fun, because they could have shut up the Republicans and said, it's your plan. And it would have come up with many of the same results. But what I have noticed in my 10 or 12 versions of the waves of health reform that have come through has been that it's personality of the two nations, which is really most important. And during the Clinton administration, a proposal for health reform, and I can't remember his name, but there was one of the fellows who was one of the architects of the Canadian system, and he and I did a series of speeches, must have been 20 speeches in Canada and in the U.S., where he would tell all the wonderful things about the Canadian system. I would talk about the U.S. system, and then in the Q&A, inevitably somebody would say to him, well, you certainly, don't you think the United States ought to have like the Canadian system? And he had this very thick Scottish accent. He said, oh, no. And he'd say, we're very different peoples. And he'd say, Canada was formed for law, order, and good government. And the United States was formed for life, liberty, and pursuit of happiness. And I notice you especially like that pursuit of happiness. And I think that has always resonated with me, because if you think of things through that lens, an awful lot makes sense. Because a number of things where I know personally about Canadian situation, and where people have told me the story, is this is a great story and this was free. Like one lady with her little girl, and it took 5 years to get an appointment. She noticed at birth when she was nursing that one eye didn't seem right. And it was only 5 years later she could get an appointment to see a specialist. When she did see the specialist, she said, don't take off your coat. They went, they had an operation because of cancer of the eye. And the baby would have been dead in another week or two or something. And she said with great pride, and it was all free. Now, this was a good story. And so my theory has always been to demonstrate the difference of personality or cultures of the two nations is, imagine if that story were on 60 Minutes in this country. All hell would be breaking loose. And we've already had a taste of, I really think if you got to Canadian like system, we would see revolution. Because just imagine remember what it was 10 years ago or so with the managed care. Government had loved HMOs and managed care, and then all of a sudden all hell broke loose because people were being told no or being told to wait.
Take another question.
Thank you for that intervention.
Yes, thank you.
We have a question over here.
Yes, my name is Steve DeBressany. I'm actually just a concerned member of the public, and I also have the benefit of having lived in Canada for several years, returning a little over 5 years ago. And my question is for Mr. Crowley. During my stay in Canada, I noticed a peculiar incongruity in terms of health care delivery. In particular, in contrast to the pervasive scarcity in essential services, non-essential services such as cosmetic procedures like LASIK, physical therapy, and dentistry were abundant, readily available, and competitively priced. So my question is, are you aware of any comparative analyses of those two sectors of Canadian health care that could shed light on the debate?
Well, it's certainly correct that as far as we can determine, and I can't say that I could point you towards any sort of empirical studies about this, but I have never heard of anybody in Canada not being able to find a dentist. I'm the son and the grandson of dentists, and so I know something about the community. And the same would be true of massage therapists and
Things that are not
chiropractors and where there is, in fact, gosh, supply and demand works. Who knew? In fact, and this is very unpopular to say at home, and I know that I will get phone calls from various people when news of this gets home. But the fact of the matter is, a very good friend of mine is the head of veterinary medicine at one of the largest veterinary schools in Canada, and he often says that you have to pay to get your animals looked after, whether you're a farmer or these are pets or whatever. But there is never any delay or queuing to do that. And if you want to pay for your dog to get an MRI, you get it tomorrow. But if you fall into the control of the Canadian healthcare system and you want it for yourself, well, A, you're not allowed to pay for it unless you go across the border. And indeed, that's one of the things I didn't talk about in my talk is the extent to which we depend in Canada on the American system. It's the secret safety valve. And I mentioned that Manitoba was the province where this debate about toast took place. Manitoba is also the province that spends the most per capita on health care in the country. Right across the border in North Dakota, in a place called Grafton, there is a clinic which was started for the sole purpose of serving the Canadian community that drive down from Winnipeg. Why? Because if you are looking for healthcare services, there's usually 3 stages. You go and see the GP, then the GP schedules you for diagnostic services, and then once they can evaluate the diagnostic report, then they decide what to do with you. And the people forget that the diagnostic service wait can be just as long as the wait for the subsequent service. And so what happens is people go across the border and maybe pay $500 for an MRI. Why? Because they can then go back to Winnipeg or wherever it is. It happens all across. They put the MRI report on the table and say, I have proof of my medical condition, and that even though people in the system resent it terribly, the fact of the matter is it pushes you up the queue. And so there are various ways in which people can get access to these services and pay for them. The shortage or the queues that are created are not in any way the result of the interplay of supply and demand. They are politically taken decisions about how to save money.
At a conversation with somebody just a couple of weeks ago, was really talking about how wonderful the Canadian system was. Everything is free, and we don't have all these terrible problems that you Americans do with all the uninsured. How can you possibly live with yourselves? And she said, and if we get sick, we just come across the border to the United States to get the care we need.
In fact, can I just tell you a very funny story about it used to be in Canada before email and all that stuff that the post office was very powerful, and the union within the post office was extremely powerful because they had the power to withdraw the postal service. And so we had annual strikes in the post office, which disrupted the whole country every year, and postal workers were extremely well paid. And I remember Madsen Peary, who's a friend of mine, who's the head of a think tank in Britain called the Adam Smith Institute, and he was talking to somebody from Canada one day about this, and he said to him, well, why don't you privatize the post office? And the response was, are you kidding? How could we guarantee service? It's exactly the same problem. Because it's a public service and we believe in the theory, we think that we can't interfere with the practice, but the practice is not the theory. They're completely different.
We have one. Yeah.
Hi, I'm David Biet from the Woodrow Wilson Center. Brian, earlier when you talked, you mentioned there's much that is laudable about the Canadian system, and I'd like you to address that too. And I think some of the misconceptions that people have here about the Canadian system is that what the Health Canada offers is as wide and large as what we get on some of our big plans here, and it's not. I mean, the gentleman here talked about dental and vision, and that's generally not covered in Canadian systems, and you have to get special riders for that. Could you address some of that?
Sure. Yes, it's a very good question. I don't want to go on too long, but let me give you a few indicators. First of all, in Canada, we spend about a little over 10% of GDP on health care. That's compared to about 16%, I think I'm right in saying, in the United States. So we are one of the 3 or 4 most expensive healthcare systems in the world. But the reason that I bring up this share of GDP is because I want to tell you what it's composed of. Roughly 7% of GDP goes towards publicly financed health care. So it's paid for by taxpayers, and it covers this range of medically necessary services. Now, medically necessary services do not include drugs, unless you get those drugs while you're during a hospital stay, and they're considered part of your treatment within the hospital. So you don't get drugs, you don't get dentistry, you don't get chiropractic and a whole bunch of other ancillary services. So while, as I mentioned in my talk, 99% of all physicians' visits in Canada are paid for by the state, it's a much smaller share that's paid of drug use, for instance, that's paid. Low-income people get something like Medicaid and so on. But generally speaking, people have to pay for their own drugs, and they get, employer benefit programs, and just like you do here. Remember what I said about the European-Canadian joint think tank study about the Canadian system. What did it say? It said outcomes when you get treatment are excellent. They're competitive with any system around the world. And this is one of the reasons why, people, this is one of the secrets of the success of the Canadian system. The fact of the matter is that most people don't have any contact with the healthcare system. The only thing they know about the healthcare system is they've been promised if they get sick, they will get looked after. And they love that idea. Those people who actually get into the system and get treated get terrific treatment. So, there's two groups, both of whom will defend that system to the death. It's the people in between, the ones who are fighting to get the treatment that they've been promised, but can't actually get because of queuing or whatever. They're the ones who have the problems with the system. And in fact,
I think it's that third group, right?
Well, if you divide the population up by age deciles, roughly, the average person under 30, between 20 and 30, consumes less than $100 worth of healthcare services a year. And in fact, other than women during childbearing years, for most of their working adult life, they have relatively little contact with the system. People who have huge contact with the system are young children and very old people. Well, very old. Now that I'm 54, they don't seem quite so old to me. Older people. So there's this sense in which what Canadians believe in profoundly is the promise of the system. And indeed, I love the promise of the system. Every Canadian thinks it's a wonderful thing. But just like the example of the post office, my God, how would you guarantee service if you privatized it in the face of annual postal strikes that go on for months? The practice of the system is actually very different than the promise. I don't know if that helps.
And isn't that really what this forum and the debate in the United States really now are all about, is the promises that are being made that really do connect with values of the American people. We want people to be covered. We want costs to go down. We want to continue improvements in quality. But the legislation itself is just not connected with that. And I think a quote today from Bob Samuelson in the Washington Post, I'm reading you the newspaper today, but he said the disconnect between what President Obama says and what he's doing / supporting is so glaring that most people could not abide it. Reconciling blatantly contradictory objectives requires him to engage in willful self-deception, public dishonesty, or both. That's from a really respected independent columnist who's saying, how do you make this work? Trying to tell people they're going to get all these wonderful new things when in fact the legislation does completely the opposite. And we actually have studies now that say that. We don't even have to wait for the laws of unintended consequences to come about. So that's the problem we have with it, that the promises are not being kept by the reality of this legislation.
We have time for one last question. The gentleman here just off the aisle. And
I'm Steve Enton with the Institute for Research on the Economics of
case that's being referred to was a case brought before the Quebec Supreme Court, not the federal, it got up to the federal Supreme Court, but it was a Quebec case, so it only deals with Quebec. What happened was there was a Quebec patient and his physician who brought a case against the provincial healthcare system in Quebec on the grounds that they had paid taxes and been promised health care services, but they had not; those services had not been delivered. Yet the law forbade them from spending the patient's own money to get health care outside the system. And the Quebec Charter of Rights, in particular, as well as the Federal Charter of Rights, guarantee something called security of the person. And the argument was that the constitutional argument was that this was therefore a violation of our rights because we could not protect the integrity or the security of our person in the face of a system that took the money, promised services, but when we showed up wouldn't deliver them and also forbade us from getting the services elsewhere. And to the astonishment of practically everybody I know, the Supreme Court actually agreed. And now, what was the consequence of that? Well, as you know, basically in Canada, in most provinces, you're forbidden by law from buying insurance, private insurance, to insure yourself against things that are insured by the state. One of the immediate effects of the Shauli decision, Shauli was the name of the physician, so Jacques Shauli gave his name to this court case. One of the immediate effects of the Shauli decision was that the Quebec government was obliged to allow people to purchase private insurance in a very narrow range of things. Basically, all the healthcare authorities around the country are desperately trying to pretend that this decision never happened. Now, but if you look at the National Post special section that they produced on the Quebec healthcare system several years ago, what was the headline in that special section? It was called "Quebec, a Province of Private Clinics." Now, what's happening is that in the interstices of the official system, there is growing up what always does in regulated markets with shortages of supply. There's growing up a gray market. And in Montreal, there are a number of private clinics where you can go and you can have joint surgery, you can have eye surgery, you can have various kinds of diagnostic procedures performed, and you pay out of pocket. Now, technically, a government in Canada that wanted to stop that has the legal power to do so, and one might even argue that under the Canada Health Act, they have the obligation to stop it. The fact of the matter is that, as I like to say, the unofficial policy now of all Canadian governments towards healthcare can be summed up in one word, and that word is hypocrisy. Hypocrisy is now the official healthcare policy of Canada. And the hypocrisy is that the system claims to provide all medically necessary services and to forbid people to pay to get their own services so that we can guarantee equitable access. What in fact is happening is that, especially in Quebec, but also in British Columbia and Alberta and other places, these private clinics are growing up in this gray area, and governments, knowing that if they shut these things down, they will be vulnerable to more and more court challenges, are essentially allowing these things to happen. And my belief is that healthcare reform in Canada will be accomplished by governments allowing the emergence of this gray sector, and in 10 years or so, they will say, oh, look at that. There's a private health sector in Canada. How did that happen? We didn't know that was happening. But, you know, since it's there, I guess we'd better kind of allow it to have an official existence. And, you know, in terms of a political strategy, it's probably not a bad one, because what's going to happen is, instead of them having to take on in the abstract the charge that the emergence of a private system will destroy public health care in Canada, what they're going to do is they're going to allow the private sector to emerge. People will see that the public sector continues to exist, continues to be financed by taxation, and continues to be available in exactly the way it's always been available. And people say, oh, okay, well, if that's what having a private sector means, I guess I'm okay with it. No politician wants to take on the argument in the abstract that this is a good thing, because there's too many people, too many demagogues out there willing to say it'll be the end of civilization as we have known it. But when you can actually experience it and see that it's actually not the end of civilization, that becomes a different proposition.
Don't you have something like that in the UK now?
Well, of course, the UK has never outlawed private provision of healthcare services. The NHS has always coexisted next to a system of private insurance. Those Harley Street doctors are almost all taking private patients. There are private hospitals. Canada is a very rare case of a system in which private medicine outside those areas that we've talked about, dentistry and things like that, where private medicine is essentially outlawed.
Brian, that marks the end of our time, but not the end of the conversation. Those of you who have the time before your evening commute, and it's going to be terrible, take a few minutes, have some wine and cheese with us at the back.
Not too much.
A little bit, yeah, especially if you're driving. Only Metro customers can take the wine. But in the meantime, could you all join me in thanking this terrific panel for a great discussion?